Good evening. My name is Karen Dodson, Program Director for the All of Us Research Program at the Medical College of Wisconsin. We would like to welcome you to the All of You Health Education session on breast cancer. Before we get started, I would like to go over a few of housekeeping items. Our presentation today has two parts. First, basics on breast cancer. Then we will have a question and answer session. Please type your questions in the chat box or hold them for the question and answer section. Edwin Maldonado will be monitoring the chat. This presentation is being recorded. Recording will be available on social media, YouTube, Facebook, Twitter, and Instagram. You have been muted by the host. Please alert the host to be unmuted. We will be doing a drawing for $25 at the end of the presentation. Our speaker today was unable to be with us. However, we do have Dr. Whittle. But first, I would like to just give you a little historical background on Dr. Amanda Mung. She is a professor, chief section of breast surgery, Department of Surgery, Division of Surgical Oncology at the Medical College of Wisconsin. Our speaker today is Dr. Jeff Whittle, and Dr. Jeff Whittle, we thank you for taking the opportunity and the time to be with us. Dr. Whittle is an internal medicine specialist in the Milwaukee, Wisconsin area and has over 36 years of experience in the medical field. He attended the Medical College of Wisconsin and has received his internal medicine residency training at the University of Alabama, Birmingham. After staying on a year as chief medical resident, he was a fellow in the general medicine at the Johns Hopkins Medical Institution, where he also received his master's in public health. He is currently the principal investigator for the All of Us research program at the Medical College of Wisconsin. Dr. Whittle, we welcome you.
Thank you, Karen. Great. So I really appreciate the chance to talk about breast cancer. It's a place where I, as a general internist, I counsel a lot of people about the steps of screening, and I counsel not a few about the options for treatment. So although I don't deliver these therapies, I'm pretty familiar with them. Dr. Kong is clearly far more of an expert in the details of surgery than I, but I'll be able, I think, to answer questions you may have about that area as well. So if you give me the next slide. So we'll start out just saying a little bit about how common breast cancer is and the risk factors that put one at increased risk. And then we'll talk about screening and the types of screening tests that are available, both the imaging tests and then the diagnostic tests. Then we'll talk about surgery, which is a big part of most breast cancer treatments, and then the other treatments that may or may not be appropriate for somebody after they've had surgery. Next slide. So breast cancer is far and away the most common cancer amongst women. You can see from the slide that it's more than twice as common as the next most common cancer, which is lung cancer. However, because we are more effective at treating breast cancer than we are at some of these other cancers, it is not the leading cause of death. Lung cancer is the leading cause of death in women, just as it is in men. Hopefully, as we move away from tobacco use, the statistic will eventually decrease. But unfortunately, lung cancer continues to be our biggest killer. Next slide. And point out that this is for 2017. So 231,000 women plus were diagnosed with breast cancer, and over 40,000 died. So it's certainly an important problem. In Wisconsin, the number of new cases is 4,850 in 2017. That number has continued to rise and I think now exceeds 5,000. The number of deaths, though, has actually decreased, but still over 700. It was 740 just 3 years ago. It is still the most common malignancy in Wisconsin as well as in the U.S. And as noted on the slide, there's increasing incidence, and incidence means new cases, and then decreasing mortality or decreasing deaths from the cancer. As I think most people know cancer is rare amongst younger individuals, and actually over the first 50 years of life, from birth until age 49, fewer than 2% of people will develop breast cancer. I think people are aware that breast cancer that does develop in young women, however, can be more aggressive, in part because we're not looking for it, and so sometimes it has progressed further when we do find it. At the age of 50, the rate begins to go up, and so the next 10 years has more cases than occurred in the first 50 years of a woman's life, and the rate is even higher between 60 and 69, and then higher still after the age of 70. So although 1 in 8 women will get breast cancer during their life, about half of those breast cancers actually occur after the age of 70. Next slide. Um, Besides age, what are the other things that make people more likely to get risk? And you might wonder, well, what do you care about things that we can't modify, things we can't change? Why are they important? And that's because our decisions about screening are sometimes affected by how high our risk is. So we'd certainly be more interested in screening a person who's at high risk of breast cancer than a person who is at substantially lower risk. And we might use a more invasive or costly form of screening for people at very high risk. So here's the risk factors. Sex or gender is not surprisingly a risk factor, although men do get breast cancer. Family history, I think most people know that if you're particularly your first degree relatives, and by that we mean your mother or your sisters or your child have developed breast cancer, then you are at higher risk. Uh, any previous breast pathology. So by that we mean previous diseases that are affecting the breast tissue. Typically, the changes in the breast that are on the pathway to cancer. Radiation exposure. Although we do chest X-rays when they're necessary, we do know that any radiation does increase your chance of a number of cancers, and breast cancer in particular. Um, the age of menses, so the time that you had your first period, is a predictor. So women who go a long time having periods are actually less likely to get cancer than women who go a short time. The number of full-term pregnancies, that tends to be a protective factor. The age at which you had your first full-term pregnancy is a protective factor. Actually, breastfeeding is protective. And then the age at which you have the menopause affects your risk. So next slide. Um, Genetics are an important contributor to breast cancer risk. I think many people have heard about the BRCA gene. There's both a BRCA1 and BRCA2, but there are a number of genetic factors that we have not yet clearly explained that also contribute to breast cancer risk. One of the purposes of precision medicine is to better understand the contribution of genetics so that we can better target therapies and screening. Next slide. Um, so when you think about modifiable risk factors, so these are things other than genes, other than age, other than when you began or ended your period, things you can do something about. The ones that come up are hormone replacement after the menopause, and although the risks that are associated with that are very modest, they are real. And so those women who have serious side effects from going through the menopause, one of the things that the doctor will speak to the woman about is the trade-off between controlling those symptoms with hormone replacement and the slightly increased risk of cancer that comes with that. Bioidentical hormones, so manufactured hormones that behave like estrogen and then can be used to treat the menopause. Unfortunately, they behave, as far as cancer is concerned, just like hormones. So we treat these just like hormone replacement therapy. Alcohol is bad for a lot of things. One more thing on the list of reasons why you shouldn't drink beyond a drink per day for women and 2 for men is that alcohol, by increasing the levels of estrogen in your blood and reducing folate, which is a vitamin that is important to normal growth of cells, you increase your risk of breast cancer. And that impact is highest in people who have gone through the menopause, perhaps because they have less fat cells than younger women to store it, and perhaps just because it's easier to see the effect in a group where there's much higher rates of breast cancer to start with. Although there have been talk from time to time that this food or that food puts you at higher risk or is protective against breast cancer. There's really not been any study where scientists would get together and say, yes, it is a bad idea to eat red meat, or yes, it is a bad idea to eat a certain vegetable or saturated fats that you find in butter. So the food choices that you eat aren't important. Now, if you eat enough of any food, though, and become overweight, and we use the term obesity, which is significantly overweight, you do become at higher risk of breast cancer because that fat tissue does produce estrogen, just like alcohol increases levels of estrogen. And estrogen stimulates, amongst other things, something called insulin-like growth factors, and they do tend to make your risk of cancer increase. So they make things grow. Unfortunately, they also make cancers grow. Next slide. People have from time to time talked about a number of potential causes, and although it's hard with science to say for sure something doesn't cause something else, we can say that when people have looked with careful methods, there's not been a hair dye study or a cell phone tower study or antiperspirants or aspartame, which is the sweetener that's in Splenda, no, in NutraSweet, or a fluoride study, or using water bottles, which have uh, typically a chemical that's been used to preserve the plastic and not make the water taste bad, or soy products. None of them have been shown to be a cause of breast cancer. Next slide. So how do we screen folks? I'll go ahead and go to the next slide. So first, it's not just how, it's when to begin. The how tends to come down with mammography for almost everybody, but I'll talk just briefly about the top two lines. So SBE is short for self breast exam. And when I started medical school, I was taught that starting at the age of 25, women should begin palpating their breasts each month, preferably around the same time of the month, so to avoid being confused by hormonal changes, and try to find lumps. And then when scientists carefully studied what we found with that, they found that having a large number of women who examined their breasts on a routine basis, were taught how to do it well and then did it, they found a lot more lumps, but they found mostly lumps that weren't important. And they did find cancers, but those cancers were found by the people who weren't doing standard breast exams as well. And in the end, people who were doing self-breast exams ended up getting more biopsies, but had no better results as far as their cancers. And so what had been something I was taught from the day one of my training, about 10 years into my practice, we figured out, it probably wasn't a very good idea. And since most women that I work with didn't really enjoy that exam all that much anyway, it turned out to be a good thing. The next is the CBE, or the clinician breast exam. So that's when the doctor does it, somebody who really knows what they're looking at, somebody who's very familiar with what cancer feels like. But it turns out when we try to have doctors do it, they don't seem to add much either. So although we still will sometimes examine the breast, especially in somebody who does not have mammography available, there's not good evidence that it detects cancers at an early enough stage that it does the woman any good, rather than simply waiting for her to notice it herself. So again, one thing that was a routine part of practice has fallen a bit out of favor, although many of the women will probably say that, well, I've had exams, and it is something that we still sometimes will do, particularly in between mammography visits. But again, it's not very well evidence-based. The last line, mammography, everybody's on board that we should do it. And here the disagreements among scientists has been, well, just how often? And I think that everybody agrees that women who are 50 years of age should start having mammograms. Everybody agrees they should have them regularly, but at that point the agreement tends to stop. So the most conservative organization, the one on the far left, says that really biennial, which means every other year, is plenty. And for women who find the mammogram procedure quite painful, that's probably good news. It gives an excuse to skip a year. The American Cancer Society, though, points out that if you look every year, you do find breast cancer slightly earlier than if you do it every other year. And they argue that even though the survival benefit hasn't been proven, it makes sense that that will lead to a survival benefit. So they really want you to be examined yearly. In addition, because there are certainly a large number of breast cancers that occur in women in the ages of 40 to 49, they suggest an earlier start. So they suggest starting mammography at the age of 40 rather than at the age of 50. And they suggest that it stay yearly as long as the woman has a substantial life expectancy. So anybody who has a life expectancy of 10 or more years, which the good news is for you 80-year-olds is that women who are 80 have well over 10 years of life expectancy ahead of them. And so it's they would argue that you should be screening people who are in their 80s, whereas uh, the more conservative group would say that after 74, nobody's really studied it. And so you're really making a reach to start doing those things. And then the National Cancer Institute is somewhere in between. What do we come from all this doctors arguing with each other about the best approach? I think what it does is it calls to mind the role that women have in their own care. Women can help the doctor to understand this is what's really important to me. I'm have a family history, or I've seen friends, even though it's not an inherited thing in my case, I've seen friends suffer with breast cancer. Anything I can do to reduce my risk, I want to do. They might be very willing to have breast cancer and mammography every year starting at the age of 40. Whereas a woman who really says, the less radiation I put into my breasts, probably the less chance I have of getting cancer. The procedure is uncomfortable. I worry that they'll find lumps that don't mean anything if they look too often, just like we used to do with the self-breast exam. I don't really want any more tests than you think is absolutely necessary, and may elect to wait until 50 and then have it every other year at that time. So it's a case where a woman should speak with the person who's helping her make decisions about screening and come to an agreement. It's really not doctor's orders, it's doctor's suggestions, and it's the patient who's the one that makes the final decision. Next slide. It is the case that finding breast cancer early does improve outcome. There's no getting around the fact for those people who don't like to get frequent mammography that earlier detection does lead to better outcomes. And here you see a slide showing that people who are in stage 0, so this is cancer that has actually not left the glands where it started, so-called carcinoma in situ, essentially all of those women will live 5 years. There are some who will have recurrences in other parts of the breast later and might die of breast cancer at a very much later time. But in terms of that cancer, nobody is going to die from that in the first 5 years after we find it. Stage 1 disease, where it has gone beyond the specific gland where it started, but is still small, again, cure rates are very, very high. And the same thing with larger tumors that have not spread to the lymph nodes, and that's stage 2. And as you get further down the path, cure becomes more and more difficult, and survival beyond 5 years becomes less and less certain. But the good news is that even at stage 4 disease, so that's disease that is spread to other parts of your body, there's a subset of women who do quite well and are still doing well at 5 years. Next slide. So the imaging tests that we do, or the diagnostic tests we do, are a little bit technical, but we'll at least touch on those in case people have questions. Go ahead, next slide. So I think most people are familiar with mammograms. We don't have a picture of the procedure, but basically the breast is compressed between 2 plates, one of which delivers a very, very low dose of radiation, which shows up on the other side and helps the examining clinician to find lumps and groups of calcifications that are typically seen in unhealthy tissue. They use the term sensitivity, that is how good it is at finding cancer if one is there, and specificity, which is how good it is at not telling people they have cancer when they really don't have cancer, to compare these. And you can see that mammography is 79% sensitive. By that we mean if 100 women with breast cancer came in and had a mammogram, 79 of them, the mammogram would show the cancer. Obviously, if it's a much larger cancer, it's easier to find, and if it's smaller, it's harder. Specificity is when women who don't have cancer come in and have a mammogram. 90% of them will have an absolutely normal test. About 1 out of 10 though will have a test that's not perfectly normal, and that is something that's a undesirable result because it means the woman will need additional testing. Sometimes simply coming back and having the next mammogram relatively quickly. Sometimes we use some of these other types of imaging. So the ultrasound, for example, is a good way to tell if a mass that's seen on a mammogram is really mostly fluid, which would be generally not associated with cancer. So it's a valuable adjunct or a helper from mammography to clarify the findings. The MRI, or magnetic resonance imaging, is a more sensitive test. It really looks much harder at the breasts and finds many more things that are abnormal. The downside of finding many more things that are abnormal is that you find some things that are abnormal but not cancerous, and probably not so abnormal they even need to be addressed. But that said, out of those 100 women who get an MRI, 90 that have cancer, 93 of them will show up with an abnormality that can be pursued. But if the 100 women come in that don't have cancer, nearly 1 out of 4 will have an abnormal result, which will also need pursuit. So a lot more time spent on diseases that are not important. So we would say, unless you're at very high risk, where that sensitivity is really important, it's probably not a great choice because you have a 1 in 4 chance of coming in for additional testing down the line. Next slide. So biopsy is something that we typically do before surgery. So even though we can tell from looking at the lump that might be seen on a mammogram or that a woman might find herself, um, we can have a fairly good sense that it's cancer. We almost always will want to have a needle biopsy, which tells us some very useful things that can help the woman guide the doctor and the doctor guide the woman into the best treatment. So by putting a needle into that mass, typically as shown in the next bullet, the biopsy is done with imaging guidance. So they can take an ultrasound, see that mass that was seen on the mammogram, and then put a needle into just where the mass is. So they seldom miss. And that tells us, then can bring out a small piece of the cancer, but can tell us a lot of things about the type of cancer amongst breast cancers that it is, and some information that affect the treatment, both in terms of chemotherapy and in terms of surgical therapy. So it's a very valuable thing that's essentially always done before one goes to the operating room to guide therapy. There might be an exception with a very, very small tumor, where the biopsy is done actually by removing the tumor with the knowledge that if that complete removal, if the removal is complete, that will be the entire surgery. And so instead of having a biopsy one day and then having to go back and have the surgery another day, you get the whole treatment and a diagnosis in the same sitting. Next slide. So what happens when you do end up having surgery? Go ahead to the next slide. So really at this stage, there's two types of surgery that are most women will go through. One is intended to conserve as much of the breast as possible, used to be called lumpectomy. And then the other is basically to remove the entire breast that has cancer in it, and that's called total mastectomy. So the entire breast being removed. In both cases, because even a small cancer, breast cancer, can spread to the armpit or the axilla, we call it, they do a sentinel node biopsy. What that means is they look at, by putting some dye near to the cancer and then watching where that dye flows, either with radiation or with simply looking at the color, they could say, oh, well, if there were tumor cells leaving that cancer and trying to spread to the rest of the body, they would have to go through this lymph node. So then they would know to remove that lymph node rather than having to take out all the lymph nodes they can find in the armpit, which can be quite a few and can lead to much higher likelihood of complications with the surgery, whether that be a local infection or having the arm on the side that the breast is removed become swollen, a condition they call lymphedema. Um, with breast conservation, with most lumpectomy procedures, radiation therapy it should be done. There may be in some situations where a woman with cancer with otherwise limited life expectancy because of other health problems doesn't benefit from radiation therapy, which is primarily designed to prevent regrowth of the cancer, which might not happen for several years. But in general, if somebody has a lumpectomy, then radiation therapy will likely follow. On the other hand, when the entire breast is removed, typically a second surgery comes along in which that breast is reconstructed, although some women choose to get by with simply using a prosthesis, so a piece of material worn outside of the body that when one is wearing clothes provides a pretty realistic mimicry of an actual breast. Next slide. So how do you choose between breast conserving surgery and mastectomy? And what I would say first is what's at the second from the bottom line, that personal preference is important. So this is really a case where the woman and the doctor should be partners in this decision. Um, and that's something where if you don't feel you're getting partnership from the doctor you're working with, you might consider at that stage, actually, especially before you've gone too far, asking why they don't want your opinion or asking for a different doctor, because it really is the case where the woman wants to should have some ability to have input. Now that said, many women would say, well, what do I know about surgery? You tell me what's best, and that's perfectly reasonable, but that should be your choice, not something that the doctor assumes. So how do you decide? So some of the things that the doctor will think through with you is how big the tumor is. Actually, the bigger it is, the harder it is to remove it and still have the breast look normal when it's partially removed. And it may be that simply taking the whole breast off and starting from scratch is going to give you better results. If there's been radiation to the breast before, it may not be possible to radiate again because radiation continues to damage the normal cells, and the more radiation that there's been, the worse. Similarly, if you have concurrent need for radiation somewhere else to start with, then again, the benefits of radiation therapy are more limited. Inflammatory breast cancer is actually a very aggressive kind of breast cancer that tends to affect the skin of the breast, and in general is not compatible with having a partial mastectomy or a lumpectomy. And then lastly, genetics. Certain people who have a very, very high risk of breast cancer are unlikely to be satisfied with the results of a partial of a breast conserving surgery because the residual breast tissue is at high risk for recurrence, and leaving it there is simply taking on additional risk that you can avoid. Um, Survival with both these approaches is equal. So when people do who are good at doing these procedures do them, the outcomes tend to be the same, whether in terms of survival, regardless of which choice is made. Next slide. Other treatments after breast surgery, basically it's either include radiation therapy and systemic therapy. And here is something where I won't really speak to this in much detail, in part because it's not a place where I'm an expert, but in part because it's so tailored to each individual. I will make the point that with things like chemotherapy, the benefits of chemotherapy tend to be pretty reproducible in terms of reducing the risk of recurrence. But in a woman who has a very, very low risk of recurrence, even if chemotherapy cuts that risk in half, it might not be worth it if their risk to start of recurrence to start with was only 1%, because that extra 0.5% might not be worth the risks involved with taking chemotherapy. So knowing the risk status is very, very important. This is another place where precision medicine does affect the practice of breast cancer. So when the breast tissue is removed and then normal cells are looked at, looking at the markers that are on that and the genetic makeup of that tumor can really affect whether or not chemotherapy is a good choice or a bad choice for an individual woman. When I started training, it was basically whether or not there were lymph nodes involved is what determined whether somebody was at high risk or not. And over the years, we identified several markers that are important. People hear about estrogen receptors and progesterone receptors, and now most people or many people have heard of the HER2 receptor. And so those three receptors all affect breast cancer recurrence risk. And the triple negative breast cancer that people hear about and are aware is a very bad prognosis means they lack all of those markers. It turns out that by adding additional markers, people can really subdivide patients into ones at very high risk and very low risk of recurrence, and really help women who won't benefit from chemotherapy in any substantial way to avoid that cost and really very uncomfortable several months for some people. Next slide. So follow-up exams are important. Breast cancer, unfortunately, runs in the family, and the person you're closest related to is yourself. So once you've had one breast cancer, your chance of another one is markedly increased. And so at least initially, we ask for a follow-up physical exam every 6 months for 5 years, and then a mammogram for at least 6 months after your initial procedure, and then yearly thereafter. Once you get, well, there's no imaging of the breast that's been totally removed. That's a good point in the next slide. And then some women actually benefit from MRI, again, because they have demonstrated that they can get breast cancer once. We might go through the extra expense and higher number of worrisome findings that an MRI generates for those women, because it's so likely that they'll have another cancer. We want to make sure we find that cancer, even if it's at the cost of having that woman have a lot more um, false positive tests. That'd be something, again, to work closely with your doctor on. Um, and then one of the things that's an important part of follow-ups, I think some women who've gone through breast cancer have a lot of discomfort related to the surgery, but most of those bad things that happen after surgery are ones that can be improved substantially by working with somebody who's skilled in the management of breast cancer. So Dr. Kong and her team are very good, in particular, at making sure that women who have had difficulties have as much of a positive outcome from treating those difficulties as possible. Next slide. So to summarize, I guess I'll especially emphasize the first two, because there are things you should take home, and that is, screening still is controversial. And so it's not the case where the doctor says, well, you're 40, you should now have a mammogram every year. They should explain it to you. Now, they may still make that recommendation because they may strongly believe that this is the greatest way to reduce your risk of cancer, and that's what you should have, because they want nobody of their patients to get cancer, which I'm sympathetic to. Um, on the other hand, women who are not fond of that screening procedure and are not fond of too much time in hospitals may well decide, no, I don't want to have that done. And so it is a discussion, not an order from the doctor. The next thing I would comment on is that if you are unfortunate and do develop breast cancer, the options that come up in surgery are ones that you need to discuss with your doctor. The doctor and you are partners in this. And although I simplified it to lumpectomy versus mastectomy, there are a lot of different options that come into that management that I didn't talk about in much detail. The last 2 points are that really more and more, as surgical techniques have gotten better, there are more and more women who can have a not very invasive treatment for their breast cancer and have a very good cosmetic outcome and also a very good survival outcome. And that systemic treatments have improved survival. So whereas at one time people said, oh, chemotherapy, that's something they give to you before you die anyway, it's very clear that the chemotherapy that we give, especially when it's targeted to people at high risk, has a really important impact on survival, and similarly hormonal therapy. So those are really good news for women with breast cancer, and I think they will continue to be better and better tailored to women's individual needs. Next slide. So these are some of the places. Wisconsin is blessed with a number of organizations that have worked hard to make the difficult life experience of having breast cancer something that they can work through. And I won't read through these resources individually, but both the American Cancer Society and the medical college's cancer department are good sources of information about that. Next slide. And I should actually say, before I go too much further, that St. Luke's does a wonderful job, as well as does the Ascension system. So the health systems that care for breast cancer in Milwaukee tend to be all very good. With that, we'll turn it over to Edwin to see if any questions have come up.
Good afternoon. Good evening, excuse me. Thank you so much, Dr. Whittle. This is very interesting here. Again, if you have any questions, please go on to your chat and put in the questions, or if it says Q&A, you can also add the questions there. There will be an opportunity also for you to be able to verbalize your question. All you have to do is just put your name in the chat so I'll know you're waiting for me, and we'll unmute you so you can ask your question. So with that said, here is the first question. Can an older woman who has found a benign lump be more at risk of developing breast cancer in the future?
So the benign lump, if the oftentimes an adenoma, doesn't appear to be related to future cancers. It seems as though it is in younger women, but in older women, I think less the case. That's an area where we've kind of changed our mind a couple of times, but if there is an increased risk, it's relatively small.
Okay. Another question. Could diabetes increase your risk for breast cancer?
It's a little bit hard to tell because diabetes and breast cancer are both increased in people who have obesity. And so I think that the connection is probably not because the diabetes directly causes it, but because women who get diabetes also are likely to get breast cancer for some of the same reasons.
Okay. Now, do women who start menstruation at an early age, like 9 or 10, tend to have a higher or lower risk at developing breast cancer?
And so early menses, so a prolonged period of having hormones work in your body puts you at higher risk.
Okay, great. Another question, with precision medicine, how is precision medicine have helped or can help in the advancement of research for breast cancer?
So it's a good question. It's I think the the two areas where I think it will be most important is one, helping us to decide when to be more aggressive in our screening tests. So I think we know that women who have the BRCA gene tend to need to begin screening at a much younger age than women who do not. And probably for many of them, a more aggressive screening posture might be the best approach. So the MRI, for example. So that's a one way. And then the second way is on the back end, where if a woman has developed breast cancer, a key decision point is whether or not they're at high risk of recurrence. And women at a high risk of recurrence are likely to benefit from a more aggressive stance. And a second key is that although we think of all breast cancers as one pot, it really is a lot of different cellular changes, and these are really genetic changes that cause cancer. And so women with cancer that's really from one genetic change probably are going to benefit more from a different therapy than women who have a different genetic cause. So precision medicine will allow us to tailor our cancer therapy to the specific problem that led to that cancer. And that's one area where it actually is in practice now. So you will see when people have breast cancers, oftentimes it'll be the case that genetic testing is valuable for management, although in some cases it's really not an important consideration.
Okay. Question from the community. How effective is hormone therapy when cancer is diagnosed early on, example, stage 0 or stage 1?
Um, so I think that hormone therapy reduces the by blocking estrogens, which contribute to both tumor growth and tumor formation, are beneficial in reducing the risk of cancer recurrence. In people with stage 0 or 1, the risk of recurrence is that tumor coming back is very, very low. That said, women who've developed one cancer, even if it was an early stage, are at high risk of recurrence. And to the extent that hormonal therapy can reduce the risk of new breast cancers, it's a population where oftentimes breast cancer or hormonal therapy is at least considered.
Okay. In your presentation, you mentioned about pregnancies having a role with breast cancers. Could you explain that a little bit more?
Sure. So the people who have never had a child, are basically at substantially increased risk compared to women who've had babies. Um, there's entirely exactly why that is not clear, but some of it is thought to be that the period of time when they're pregnant, the amount of estrogen is less, and that may affect how the breast develops cancer. Then women who have more babies tend to have um, less of a risk of breast cancer. The most important benefit is the first baby, but it is the case that having more than one is better still.
Okay. And talking about pregnancies, if a woman has her first pregnancy in the 20s or 30s, does this increase their risk?
No, actually, well, compared to having it in their teens, it does increase their risk. So the earlier, in some ways, the better. So women who have their first baby when they're quite young uh, have a somewhat lower risk of breast cancer. Now, there are a lot of other biologic reasons why having babies when you're not fully mature, so in your teen years, is probably not good for your body overall. But in terms of breast cancer risk, it does seem as though the earlier you have that period where the breast develops in response to a baby, the less risk of breast cancer. Again, modest additional benefit as you get younger and younger, but it does seem to be the case that younger is better.
Great. How large does a tumor need to be before a mastectomy is considered as the best option?
So we would start to get into places where Dr. Kong ought to be on the call, but I think even she would say, it's very dependent upon where in the breast that is. So a large tumor that's right underneath the nipple or the areola, the dark area around the nipple, that's going to be very tough to get out. And on the other hand, a relatively same size tumor that's located high up and towards the middle of the body might be far enough away that really is even a fairly substantial tumor can be managed with a lumpectomy. So the variation in size is really dependent upon the location and the size, and to some extent the way that the cancer appears on mammography. So it's and even when they do that, the surgeon will always say going in, so we intend to do this. When we get there, there may be findings that really cause us to need to rethink that. And they'll try to have a plan mapped out with the woman. And there are people who have gone into surgery and had findings that were surprising to the doctor, and based on prior agreement, they basically start over again. They wake the woman up. Okay, now we know this. Let's talk. They don't do it right there on the table, but there would be it wouldn't be unreasonable to stop and rethink things if things are not as expected. Most of the time, though, the doctor will have talked about, well, if this happens, this is what we'll do, and come to an agreement with the woman prior to surgery.
Okay, thank you. Got another question here. I'm trying to set this up. It's not happening, but are there any foods that may increase the risk of developing breast cancer?
Any foods?
Yes.
Yeah, so I think that there have been a number of times when people thought they said, "Oh, yep, this is the problem." I think that probably red meats and other forms of saturated fat have probably been the most commonly mentioned. But when you control for diet and other not diet but weight, it turns out that it's pretty hard to find an effect. So as of today, we don't say, "Oh, you can't have this food or that food." The only exception would be alcohol, to the extent you consider that a food. It appears as though it does increase risk.
Right. Does breast reduction surgery reduce the incidences of breast cancer?
I am not confident of that. My understanding is not, but I actually don't know.
Okay, great. And can birth control with hormones affect the risk of developing breast cancer?
Yeah, so there's been back and forth around hormonal therapy, but it is the case that particularly with the most birth control pills do decrease the estrogenic volume, the amount of estrogen that your body is producing spontaneously. So in general, the sense is that there's probably a reduced risk of breast cancer in women who are taking the pill. Certainly, ovarian and breast cancer seem to be less in women who are on the pill. Um, Obviously, the effect of not having any pregnancies would seem to operate in the opposite direction, but the pill itself, in a woman who's had the same number of pregnancies, women who have taken the pill seem to have less cancer.
Okay, great. Another question we have here is, does breastfeeding affect the probabilities of breast cancer?
It's been, I think, hard for us to find an effect on that. So I guess I would say um, it is not proven, so I would say there's not a known benefit and not a known risk.
Okay, great. Now, I know we've talked about the breast cancer in females. I'm going to ask you this question. What are some of the warning signs or symptoms for a man who might be a candidate for breast cancer?
So they are fairly similar. I think that with men, because the volume of the breast is typically substantially smaller, it's the lump that's going to show up, that abnormality in the breast, and in particular a lump that's not centered over the nipple. With men, a lot of things can make the breast tissue that lies underneath the nipple grow substantially, and men find that very worrisome because it doesn't seem normal to them. When it is centered under the nipple, then it's probably simply the breast tissue growing as one might expect it to. If it's eccentric, so it's on one to one side or the other, certainly makes you more worried. Only one side having it compared to both sides, because the system things that make you get breast for men generally tend to be affect the whole body. And then the quality of the lump, how hard it is, and then changes in the overlying skin. So if the breast is enlarging, but the skin simply it looks the same as it ever did, that's less of a problem than if the skin is kind of dimpling around where that nodule is. That would also be worrisome in a woman.
Okay, great. So I want to remind everybody attending also, if you have questions, please feel free to put them on chat or the Q&A section. So far, we've gotten a lot of great questions, and have one more, doctor, for you. If a woman's mother found the lump and it turned out to be benign, is it still recommended that the daughter start early testing between 40 to 50?
Good question. I would tend to say no. There are people who are with the American Cancer Society who are the most aggressive would say she should be checking between 40 and 50 regardless. They would say that everybody should be checking between 40 and 50. I think that the fact that the mom had a benign lesion at that time wouldn't really affect things. I'm going to actually, I've kind of glanced off to the side at one of my reference works, and as I was reading about breastfeeding in particular, I admitted I didn't know for sure that well. It turns out I came down in the wrong place. So the best estimate right now is that there is a protective benefit from breastfeeding. So they suggested that for every 12 months of breastfeeding, there was a 4% lower chance of breast cancer. So if your chance was 1 in 20, it would instead be probably closer to 1 in 21. So not a huge change, but a change in the right direction. So breastfeeding, it is a benefit in the most recent studies that I just took a look at as we were talking.
Great, thank you so much. At this time, if anybody is interested in asking a question, you can go ahead and unmute and ask your question. Okay. Just want to remind everyone that all these questions will be part of the recording along with the answers. If you have other questions that come up after we're done, please feel free to send them to us, and we'll have an answer posted along with the question posted along with the answers at our moment. Dr. Whittle, thank you so much at this time. Thank you so much for everything and information. It's been very helpful, and we're going to continue with our presentation. Thank you so much, Dr. Whittle.
My pleasure. Thank you.
Thank you, Dr. Whittle. Now it's time for the drawing for $25. We'll be checking the attendee roster now and randomly selecting one winner. We'll confirm via phone or email within 48 hours if you have won. Once we reach out to you, you will have 2 weeks to respond. So I'm going to mention the drawing. It's going to be, I'm just going to read the initials, and it's JG. So the individual with JG will be reaching out to you for your $25 cash that will either be sent to you or we'll make arrangements, however. Next, Christian. Just want to mention to you that in November we'll have lung cancer and then and actually respiratory. And then Alzheimer's and dementia will be the 18th of November. After this event, please take a moment to complete the short survey. You can also email us at allofus@mcw.edu with your suggestions. You can also contact me, Karen Dotson, as the program director. We're located at the Medical College of Wisconsin, Curative Building, 1000 North 92nd Street, Suite G150. However, we're not open right now for people to walk in, so we would suggest that you call, and you can call. The phone number is 414-955-2689. You can also reach out to us at allofus@mcw.edu. You can also reach out to us at All of Us Milwaukee, and then that would be our Facebook as well. And then you can also, you have other options as far as if you want to join the All of Us research program, you can reach out to joinallofus.org/Wisconsin. You can also follow the Medical College of Wisconsin page and get that information as well. Okay, I would like to thank everyone for taking the time to be with us today. This was a wonderful opportunity to be able to really get some good information about breast cancer. And we hope that you're able to join us in the coming events as well. Everybody have a wonderful evening. Thank you. Bye-bye.